Good morning, everyone. Thank you so much for being here. I'm Rebecca Pratt, Co-Associate Director for Community Outreach and Engagement, and I'm really thrilled to be able to introduce Dr. Nasra Giama today, who I've known for quite some time, and I was just delighted when she agreed to come and share her work with us today, so thank you so much. She is a women's health nurse practitioner and a public health nurse, interested in the intersection of health, education and culture, with a primary emphasis on health promotion and prevention in immigrant and refugee communities. Dr. Giama is a clinical associate professor at the School of Nursing here at the University of Minnesota and an assistant professor of medicine at the Mayo Clinic. Dr. Giama provides professional, scholarly leadership in 4 primary areas, one being health promotion and prevention, the second being scholarship focused on methods to promote the health and wellbeing through community engagement strategies, the third being transforming health equity and social justice and nursing education, and then finally mentorship for diverse students in healthcare. And boy, has she done a really great job in all of those things, and really been a leader in the area of liver cancer detection, which is a growing but incredibly important area, one that affects our catchment in many Minnesotans. So thank you so much. Extend my warm welcome to Dr. Giama, and please take it away.
Good morning, everyone. I'm Nasra. It's good to meet you all. Thank you for having me this morning. This is a group that I've been wanting to hang out with for a while, so I'm happy to be here and share a little bit about the work that my team does related to liver cancer early detection among our communities, our newer immigrant communities here in Minnesota. I have no disclosures to share with you. The goals of my talk today is really to talk about liver health disparities and how they affect immigrants and refugees, specifically here in our state of Minnesota. Talk about some of the barriers that we found that hinder successful, sustained community engagement. And I'll focus it more on viral hepatitis and liver cancer treatment and prevention. But I think we can extend some of those barriers as well as assets or strengths to other cancer groups as well. And then we'll talk about how we build community strengths to address cancer disparities and some of the strategies that we've used to develop long-term commitment and sustainable outcomes. To give you a little bit of background, in the United States, immigrant and refugees account for approximately 13% of total population. And as many of you know, refugees really contribute to the cultural richness of the state of Minnesota. Minnesota has welcomed refugees here for a long time. In 1979, we saw more than 100 countries being resettled in Minnesota, and that number had steadily increased until around 2020, our numbers started to drop. And a part of it had to do with COVID, but slowly our state is starting to receive more people being resettled here again. Oops, sorry. In Minnesota, again, immigrants and refugees are about 11% of the businesses in the Twin Cities, and being a member of these refugee communities, I wanted to focus some of my work here. I have a personal vantage point, again, being a refugee to Minnesota, and specifically when we talk about liver cancer and viral hepatitis, for me, it's especially meaningful because it has also impacted my own family. I'm from Somalia, and Somalia is part of sub-Saharan Africa, a part that is endemic when it comes to viral hepatitis. I've also had that privilege to be living in the United States and have access to higher education, and to have this background before I came to graduate school here at the university, where I was a public health nurse and I did a lot of breast cancer education. So cancer was already on my mind. And then having heard about family members suffering from liver cancer, I started to think about how do I make this part of the work that I'm doing. And then there are, as I moved into graduate school, I started working as a research coordinator at Mayo Clinic. And that's really when I ended up in the liver cancer world. I was coordinating studies with hepatologists and liver researchers. And that's really when I started to learn about some of the work related to liver cancer. And in 2010, when I started graduate school here at the university, at the same time, there was a study published by a team at Mayo Clinic called Viral Hepatitis Among Somali Immigrants in Minnesota. And this study looked at this was a hospital-based study where they did a chart review and looked at we know that Somalis are coming from a part of the world where viral hepatitis, especially hepatitis B, the World Health Organization tells us that this is an endemic virus. We know that hepatitis C, we don't know what it looks like in Somalia because that data has not been available. Also, Somalia has been at war since the early 90s with unstable healthcare infrastructure. So really there was no data keeping, anything that really told us what did the rates look like now that we're in the 2000s. So Dr. Shida, Dr. Roberts and the team did a retrospective chart review and looked at what are the reasons that Somali patients are coming to Mayo, because I know we're seeing them for liver cancer. Oftentimes they're in really, at a level where we can only offer palliative care, that we're not able to offer some curative treatments. What are the underlying factors? And in this study, what they found was that when they did an age-adjusted incidence rate of chronic hepatitis B among Somalis, they found that hepatitis B was 10-fold higher than non-Somalis. The study also found that chronic hepatitis C, which we didn't have any numbers, how does it look like among the Somalis coming to Minnesota, that they found in the patients that they were seeing, there was a 3-fold higher chance if you are Somali of having hepatitis C, and that the age-adjusted incidence rate for liver cancer among Black Minnesotans is 4.2% higher than that of white non-Hispanic Minnesotans. Interestingly, in the same study, we found that for the patients we were seeing with liver cancer of Somali background, hepatitis B was a larger factor for developing liver cancer, where oftentimes in the United States we see liver cancer with both, but more in the hepatitis C group. So this is the study I came in as this study was being published. And we were thinking about, now that we knew this information, well, can we validate, can we see what is really happening in the community? Because again, as a tertiary care center, these patients were coming in because they had liver cancer, and we were kind of going back and saying what's going on with them. But in our healthy population in Minnesota, what can we learn about this virus? So we started doing a community-wide screening program across the state of Minnesota, where we went into communities and asked people to give us a voluntary blood sample, and we would check for that sample hepatitis B screenings and hepatitis C screenings. But again, Somalis have been in Minnesota for 20 plus years, close to 30 years now in the United States and in the West. There were some challenges when recruiting the communities to research. We started with the Olmsted County population in Southeast Minnesota, and as a research coordinator trained here in the United States, I was like, let me use my normal methods that I use with all of my patients. So looked at the chart, saw the patients who identified themselves as Somali or who had Somali names from our electronic health records, and mailed out 100 letters. How many do you think I got back to say, hey, we'll participate in your study? Two. Good guess. I got one back. I got 1 out of 100 letters, and I was so confident because I was doing that with all of my other studies. With my cholangiocarcinoma studies, I would send out a letter, I would make phone calls, and that was working. I would, if I would send out 100 letters, maybe I'll get 20, 30, but I'd get a lot of people calling me back. With the Somali study, I sent out 100, being very hopeful. Like, people know my name. I've been in Olmsted County for a long time. I grew up in this community, but even then, we got 1 letter back, and that individual was a nurse at Mayo Clinic. So this is an individual who's already in our system who responded back and said, hey, I'll participate in this study. So we went back, right? So I'm of Somali descent. Dr. Shida is also a Somali researcher, trained in the West, but really started his education and his practice back in Somalia. And we started to think, what is a different way that we can approach this so that we have community buy-in and we have participation? And we started thinking about what are the challenges, when we talk to people related to participating in a clinical trial, in a clinical study. And health literacy became a big thing. We were sending out letters that were in English, and we, didn't think about, first of all, how many people in our population could really read English, and also how many people can read in Somali. The Somali language was written in 1972, and that's, before that, people were reading in Somali, but they were using Arabic font, and now Somali is used in Latin writing. So many people didn't have the opportunity to actually formally be educated in Somali. And then when we wrote the letters in English, that was also an issue. So we started thinking about what are the literacy level of people. Trust also became a big factor. That was a challenge for us. Hepatitis B is a common, viral hepatitis in general is commonly known among Somalis. If you mention viral hepatitis, it's translated literally into Somali as jaundice, or changing of the skin to be yellow is the literal word for hepatitis in Somali. So if you say it, people are like, oh yeah, we're familiar with that. Oh, I had that, or my sister had it. I have a burn mark on my arm, the back of my arm. And that's a sign that a person had maybe viral hepatitis, maybe hepatitis A at some point. They got sick, they were burnt, and that was supposed to be the curative treatment. But people didn't understand that hepatitis A, B, and C are different, and the risk factors and the causes, what these do to your body, are different. Also, people who were hearing that, oh, so-and-so showed up at Mayo Clinic with liver cancer and they died. Right? So that trust, that fear of, when we talked about viral hepatitis, the connection to liver cancer and the fears of coming to this hospital for care was also there. So trust became an impairment to participating in the research study. Other people asked us, am I going to be used as a guinea pig if I give you my blood sample? What's going to happen to my blood sample? So those were some of the other fears we were seeing. The time was an issue, history of research or with research. People just had never participated or never asked to participate in research studies. So they just were not sure, what does this entail? What does it mean for me? And then the resources that we didn't have, our IRB at that time had the consent form. They had a short consent form, which was like a 2-pager translated into Somali, but we still had this like 12-page English version. And we didn't have the human capital of the person sitting down who could read the consent form and translate it to people in their own language. So human capital, interpreter, research platforms, IRB forms were not in Somali. And there was no audio version. In 2024, we can take anything, put a QR code on it, and that could read it for us. A person can listen to the audio version of that. But early in 2012, we didn't have that available to us. So we, as a research group, had to step back and say, these are the challenges we're facing when we try to use the traditional approaches of recruiting people for research. Letters, phone calls are not working. What's another way that we can go about this? And this is when we started really thinking about, let's go back and use our public health lens. What can we learn from public health and population-based research? And we started thinking about community-based participatory research as a method to really partner with communities to participate in these studies. And as many of you know, community-based participatory research is a collaborative process between community-based organizations and academic investigators. And it has the potential to really make research more responsive. Because we're listening to the voice of the community and what are the current needs, but also able to take on what are some of the things that we're seeing and the concerns we have from healthcare, from the health issues that we're seeing in our patients. So again, after seeing the need to provide community engagement, that there was need for education and better ways of doing outreach, we decided to use this community CPPR methodology. Some of the advantages of using CPPR, it acknowledges the community as the primary unit of identity. We were able to go back to communities and find out, what organizations do you work with? Where are people getting services? Where are people hanging out? Because obviously they're not showing up to the clinic unless they're sick or there's a family member that's sick. It enhances and builds on existing strengths. It really fosters a collaborative relationship, and I'll be able to show you how it has fostered collaborative relationships for our research group. And knowledge gained through the partnership can be translated into specific actions. There are tasks that can come out of this that we can do together. So with the work that we're doing, when we tried keeping our staff in the clinic and saying, hey, use these traditional methods of recruiting people for a clinical study, we know that that wasn't working. So we decided, go where the people are at, using the clinical, the CPPR method. And we started with, what are events that are happening in the community, in Southeast Minnesota, in every August, across the state of Minnesota. That year when we started this work, it was happening in the city of Rochester, but there are soccer tournaments that happen, and youth from around the United States who are East African come and they have these large soccer tournaments, and a team is usually chosen to receive the cup that year. So we started with there. We knew we would have hundreds of people out there, and we said, can we sponsor your event? And can we have 5 minutes of the time? They had musicians, different things going on, just to introduce ourselves and introduce the work that we're doing, and then we would have flyers there. So that was our first community event that we went to. we started going to the mosques in Rochester, St. Cloud, community masjids here in the Twin Cities, in the city of Mankato, Awatana, and Faribault. So kind of try to send our team out to everywhere that we knew that there was a Somali community, and asking for time on Friday prayers. We know that large numbers of people come out to Friday prayers, skewed towards the male population. Many more men come out than women, but still we knew that the message would get out to the community. So we started going to Friday prayers, and they would give us 5 minutes or 10 minutes of their time and say, at the beginning, while everybody's sitting there, let's introduce ourselves. So Dr. Shide or myself would go up and mention what we're doing, say we're from this institution, and we're doing this research study. And we didn't ask people, hey, come and participate in the study, but we would be saying, on Saturday we're going to come back and we're having a seminar to talk about liver disease. You're invited. Please bring people from your community. And we started holding these monthly seminars in different spaces. A lot of it were at the masjids, some at charter schools, some at many apartments that large Somali communities live in, usually have a community room. So we would bring refreshments and hold a seminar and just do step back from the research and do some education about viral hepatitis, liver cancer. What does early detection look like? How do you establish and advocate for yourself when you're talking to your providers? So we started doing those sessions with people. We started doing those educational seminars with people to talk about what is liver disease. And then at the end of an hour-long session, we would say, and by the way, we're doing this liver cancer, hepatitis B and C screening program. We would love it if you would participate. And at the sessions, initially when we started, we would have anywhere from 15 to 20 people, and we would have about 5, 6 people who would sign up. But then when those 5 or 6 people would sign up, they would bring along another friend or family member. And we started it so that, in Rochester, we would invite them to come to the clinic to give a blood sample. Or if they had an upcoming appointment, we would say, hey, you're already having blood draw done. Can we collect a couple extra tubes for the research? In the Twin Cities, we actually use the mobile health clinic services. This, I don't know what we call it here at the University of Minnesota. At Mayo, they have a CRU where they have a van that can go out to different communities. They'll send a lab tech with you who can do the venipuncture blood draw for you. And then our research team, luckily, I spoke Somali. We ended up getting a PhD student who also was, who was Somali speaking, and then Dr. Shide, who was Somali speaking. And we were really great that we had 3 people who spoke the language, who looked like the people that we were asking to participate in the study, because then it just gave us a little bit more buy-in from the community. So we did that for about 2 years. We even went to adult daycare centers, adult centers, we should say, adult day centers, and we would do presentations and provide lunch for them and just say, let's talk to you about liver disease and how many of you know about your hepatitis B and C status, and then offer people for this free screening if they wanted it. So we started doing it that way. And from there, we were able to recruit close to 800 people from the Somali community over a 6-year period that we would be going out to different community centers. But as we collected samples, our responsibility is anytime you're screening somebody for hepatitis B or C, there are results that come out of this, and we have to give these results out of it. Follow-up became a challenge for us, right? So we were now able to get people at every community event that we went to. We would at least have 3 people who would volunteer to give a blood sample. But then the Somali community, as some of you who may know, who work with them, are very transient, and they live in one area, and phone numbers change easily. People move around a lot depending on where there's work or where there's family. So we started losing people as, a month later after we would collect their sample when we wanted to give them their results. There was also lack of understanding to the research process that, because we have your sample, we want to give you this piece of information that's going to be really helpful for your health, right? You need to either get vaccinated or you have chronic B or C, and it's really important that you go see a primary care provider. But people didn't know that this, this would be the follow-up piece that came with it. So some learning for our own research team to say, it's fine, it's great that people are participating, but what responsibility do we have to them to be able to educate them when we have them in that setting to understand what the results might mean for them? And then I mentioned some of the translation things for consent forms and educational material. Once we had, we did these seminars, as I mentioned, these educational seminars for 3 years or so. We started thinking about how do we build our research team's capacity to do more. Because we were using a CPPR methodology, our team really cared about liver cancer and viral hepatitis, but the community was telling us we have other concerns. Diabetes kept coming up as a concern for people. Childhood illnesses became a big issue that came up. This was also happening at the same time where we were having a lot of talks about measles and the MMR vaccine, and parents were coming us to us, yeah, the viral hepatitis is a great thing, but it doesn't impact me, but this is the issue that we're seeing in our community. How can you guys help us with this? And to be really, truly using a CPPR method, we had to listen to what the community was saying. So we started creating this community coalition. And this community coalition was a volunteer advisory group that we set up along, initially starting with our research team, but we were able to recruit members of the Somali community who were either in healthcare and education or some sort of community, had some sort of community responsibility from the Twin Cities and in the Rochester area. When we were creating this community coalition, some of the things that worked well for us is having a plan, making sure we understand the purpose of doing this, why we were asking people to participate. Using a theory or intervention. And again, because of my background in public health, I was able to use the community coalition action theory to build this group. The theory really gives you ways of thinking about the different phases of coalition building, that you have that honeymoon phase where people are really interested in participating, but how do you carry them on into the second year and third year and follow on to create a sustainable group? Building on assets and passions, so understanding, for example, a big concern that was coming in was childhood immunization and the vaxxers. So finding people who were interested in that work and inviting them to come and serve on with us. When we thought about diabetes, we actually recruited a research team from Mayo who was already studying diabetes in East Africa, and said, hey, can you come and can one of you join this coalition, because that's a concern we're hearing from people. And it worked well for them because they were having a hard time penetrating the Somali community, and the community was saying, hey, we care about diabetes, please listen to us. So it kind of created a nice network for them as well. And then sharing leadership, right? Not making sure that us academics or researchers were taking the leadership, but really giving that to the community to say, can you serve as the chair or the facilitator for this? While we in the background were able to help out and find grants to support the work of the group. So some of the things that worked for us when we did this coalition building is the importance of understanding cultural beliefs and viral hepatitis, making sure we have a culturally compatible project team and target community, really using a partnership model and using different forms of communication. And I'll just give an example of what I mean by that. So this is the advisory group that we created with the community back in 2013. It's called the Somali Health Advisory Committee. The members of this group are from the Somali community. They are diverse in their age, gender, tribal affiliation, educational level, and their time of migration to the United States, immigration to the United States. But the coalition also has members that are not Somali, who are interested in working with the East African community. So many researchers, educators, students. We get a lot of medical students who stay with us the 4 year in their medical school as part of their community work that they're doing. I mentioned to do the community-wide screening program, we had to have a lot of partners, right? We had to step out of the clinic and go out into the community. So initially we started out doing the screening program with just the Somali community. But again, we were hearing from other African communities in Minnesota, hey, like liver disease also impacts us. Can you do some work with this? So we were able to find a small grant to help us do screenings for them. So we were able to partner with the Organization of Librarians of Minnesota. They have a large church presence where they have nurses in their church. I'm trying to think about what that was called. When you have a nurse who works in the church and they kind of run the health part of it. The term is not coming to mind right now, but they have nurses who are in part of the churches, and they would do blood pressure screening. So we partner with them to offer free screenings to members of the Liberian community. We found a clinic that was attended mostly by Kenyan communities, a community-based clinic. So we partner with that doctor at that clinic to offer the screening. So he would host a hepatitis screening day, and members of his community would come and would offer these free screenings. And then I mentioned some of our funding came from Gilead, Genentech, Mayo Clinic. And then we found a lot of community-based clinics. So things such as Access Medical Center, Gerkar Medical Center, the Bryan Call Center, Hep B United, partnering with these organizations who we knew were already working with the community and bringing our research team and actually setting up in their lobby and offering their patients or the members of their community free hepatitis screenings, and then going to community centers such as mosques I mentioned. It's a lot of work on the research team, right? So you're in Rochester and you're driving an hour and a half or 2 hours to go to St. Cloud. But we had to understand the value of this. This is what our community was asking for. And for us to really make the impact that we wanted to really understand how does viral hepatitis, we know what the hospital-based patients are telling us, but how does it look like at a population level? We had to go out to the community and do the screening. And that was a big lesson for us. So from that, we published this paper called, we published this paper 2 years ago in the World Journal of Gastroenterology that kind of details what we found from our research study. And what this paper confirmed for us, well, what the research confirmed after doing the screening for 800 Somalis was that there is a prevalence of chronic hepatitis B and hepatitis C among Somalis through the community-based screening program. So just kind of validating what we learned in the hospital. It also validated for us the importance that there's a gap from a person finding out that they have hepatitis B or C to that linkage of care. Many times they would have primary care providers who did not provide the follow-up that's required. When we asked them how many of you have a primary care provider, many of them had not seen it for a long time. And we stepped back and said, when a person comes to the United States, what happens with hepatitis B, right? It's required by the CDC that a person in that first 45 days that they're in the United States, if they come in as a refugee, they get screened for hepatitis B. But imagine you're in a new country, right? You are working through that process of resettlement. You're establishing a home, getting a job, getting your kids in school if you have any, adjusting, psychologically to living in a new environment. And you're told you have hepatitis B, and it's translated to you as you have agartho, which is jaundice, which is not a big deal from everything you've heard as a child when you're back home. And that diagnosis is put on you, but it's never carried forward. So people have been here for 20 years or so. At one point, when they first came to the country, they were told they have hepatitis B, but it hasn't come up again. And for some people who, like myself, may have been brought here as a young child, they were never screened. They were just vaccinated because the assumption was they're a young child and the exposure isn't there. So many of them were screened, and now as adults or as women giving birth, it's required that they have hepatitis B screening, regardless if you have, if you've had vaccination. It's part of that protocol for having a baby in the United States. So at that point, they find out in their 20s or 30s, they have hepatitis B. But then when they look at their immunization record, it shows up that they're vaccinated for Hep B. So it just creates some conflict for us. And that was the conflict we were seeing. We would call people and we say, your labs are telling us you have hepatitis B. There's a risk for developing liver cancer at some point. It's really important that you create a connection with the hepatologist or a primary care provider who understands this, and that you have regular follow-ups for early detection. And they would say, I'm vaccinated, what are you talking about? And it would kind of, for us, it was a big learning lesson. So the work that the next step we did was do this knowledge, attitudes, and behavior, talking with African immigrant communities, Somalis, Liberians, Kenyans, and Ethiopians in Minnesota. We talked to about 40 people from each group, and we did this community listening sessions to understand what is your understanding about hepatitis. Are there other things that contribute to liver cancer? In the Somali community, we know hepatitis B and C are big factors, but we don't know so much about the other communities. What are the understandings related to these viruses, and then other risks for liver disease? And some of the things that came out of those listening sessions were the lack of insurance was a big concern for the community. For some of the people who didn't come to the United States as a refugee or through a legal immigration process, there was concerns about the legal status of being in the United States and how does that impact me if I go and see a doctor. There was limited health awareness, language and cultural barriers, and really a focus on those that were left behind. People who were working as in the United States as refugees to really support family back home and kind of disregarding their own healthcare needs. The community listening sessions also told us that community engagement is key, including both the participants and then also the clinicians and researchers, that we needed to have better relationships with each other. That we need to show compassion and genuine concern, that it takes effort and time. I mentioned all the work, all the effort that it took just to do this community-based screening, so that when we are seeing somebody as either clinicians or researchers, we just have to be able to really genuinely communicate with them and help them to build that research knowledge to be able to participate in clinical research, that community leaders in institutions can be trusted, and if that trust has been broken at some point, or if there's some fear, stepping back and asking yourself, how can we really use the community engagement lens to bring people along with us? Addressing community awareness to reduce stigma and silence, and advocating for structural changes. We also learned that within some of the communities, there was a lot of secrecy related to the diagnosis of having viral hepatitis, that it was often maybe associated with HIV, or people didn't understand HPV and HIV were two different things. So there was secrecy around it, and they were not disclosing it, although they may be participating in some risky behaviors. So thinking about how do we reduce some of that stigma that's related to the virus, and increase people's awareness and ability to either share with their providers or share with others. Some individuals talked about in this, I know I have Hep C, but I'm afraid to even tell my doctor, right? If I have a new primary care provider, I'm afraid to disclose this because I don't know what this will mean for the care that I'm going to get. So trying to reduce some of those barriers that exist. As we move forward, some of the key messages that we continue to share through the work that we're doing is treating hepatitis B to decrease viral load really reduces liver cancer risk. And as I say this to you as a group of, either educators or researchers or students, that makes sense, but try to translate that into a different language. Try to translate this to a community where the word cancer sets out an alarm in somebody's head, right? And to try to reduce the association that because you have viral hepatitis does not mean you have cancer. But we want to prevent or detect it early if it does show up for you. Also, treating hepatitis C to cure the disease reduces liver cancer risk. So we're thinking about and working with communities to try to put this in a language that's understandable for them. For some of the communities, alcohol was actually a bigger factor for liver cancer versus hepatitis. So thinking about how do we create messaging around reducing alcohol use to reduce liver cancer risk. And again, as many of these communities stay in the United States longer, we continue to see the trends of obesity and body changes that, the metabolic changes that happen over time. So lower weight is associated with decreased liver cancer. Now, if you couple all these certain things, whether if you have Hep B, if you're using alcohol, if you have a higher weight, your risks for liver cancer are substantially higher. So trying to, in saying it's even reducing one of these risks, right? Reducing alcohol use, losing weight, will actually in turn reduce your risk if you have viral hepatitis. So trying to do some of that education. So again, having more than one risk factor multiplies the risk of cancer. And how are we doing this today? Our SHA group, the Somali Health Advisory Group, continues to meet bi-monthly. Hepatitis and liver cancer is a standing part of the work that we're doing. And then there's a subgroup of us that really focuses on community education and awareness related to viral hepatitis. But there's other members of our community, of our group that work on, there's individuals who work on Alzheimer's, some people that are working on increasing clinical research clinical trial participation. And they created a video a couple of months ago with a team at Mayo Clinic's Cancer Center to talk about in Somalia, how do we increase cancer trial participation, because like you guys are seeing here at the University of Minnesota, the same with Mayo Clinic, our participation from our African and African American communities is substantially lower in clinical trials. So just trying to increase people's awareness about the clinical trials. When there are community health fairs and workshops, we always try to sponsor, table those events, really without any agenda of getting people to participate in a clinical trial, but again, share some of those key messages about how do you talk to your provider about hepatitis B? Are you screened? Do you know what your status is? We are in the process of setting up an African Providers Network. We had our first event last summer where we did a workshop for primary care providers serving the African immigrant communities in the Southeast Asian community about how do you care for your patient who has hepatitis B and C, and how do you set up a liver cancer surveillance program. And we continue to serve those, support those community clinics, and really trying to grow this network and having continuing education hours for them at least twice a year. So if any of you are interested in participating in that network, we are always recruiting more members to join us. A big part that we're doing, that we've done the last 4 years, 3 years since COVID started, was partnering with media. Because of COVID, we were not able to do the community-based activities we were doing, which are the health fairs, workshops, education at the mosques. So really partnering with Somali TV, some of the Facebook groups, to set up live days where we do education about viral hepatitis and liver cancer detection, and then slowly building on our social media marketing. That's an area that myself, I'm not very strong on, so really leaning on my peers to be able to step in and do some social media marketing. There's a video that we created I wanted to share with you all. Audio is not going to work. I don't see a lot of Somali speakers in this room. I'm assuming a lot of you don't speak Somali, so it's okay, because the video, the narrator is speaking in Somali. He has a great voice, and I'm happy to share this with you. But one of the ways that we're trying to increase community education is make information in layperson language that's accessible to them, that they can, it can be played in clinic rooms or while a patient waits for an appointment, or they can go to YouTube, and if they search hepatitis B in Somali, this type of video will come up. So hopefully I can play it here. I just click. Yeah. Check it out.
There we go.
There you go. So what we did with this video is it's about hepatitis B awareness and really trying to push people to linkage to care. So a little bit of background about hepatitis. The audio is in Somali, but the subtitles are English. So trying to hit the different groups who speak Somali or who understand English more, whatever language they prefer. So kind of trying to show different ways that a person can get infected, that it's asymptomatic for oftentimes for people. And I wish you could hear his voice, because he really has a great voice that's narrating it. So trying to show how it progresses to creates these changes to the liver. So at this point, we're trying to drive home the thing that if you have viral hepatitis, even though it's quiet in your body, it may be causing changes to your liver. And oftentimes when symptoms show up, the disease may have progressed faster, and that's why it's important to have that linkage to care. We also know that a number of families will say no at that baby, the first dose that a baby gets within that first 24 hours is for hepatitis B. And some families in the Somali communities, because of fears of immunization, will say no. So we wanted to make sure they got that message that vaccination is important in birth, at that birth dose. And we don't have a cure for Hep B, unlike Hep C. So trying to tell them this is an ongoing thing in your body. And then that last piece of really why it's important to be linked to a provider who understands this, either a primary care provider who really knows what they're doing, or a hepatologist that you can see once a year who orders your lab and does your ultrasound. And one of the things we're trying to work with many of the hepatologists across the state is setting up some sort of surveillance program that automatically reminds people, right? So if you are a provider, you know, for your patients, you know, either doing a phone call or sending a letter or something, or a text message, say, hey, it's been 6 months, it's time for you to get labs done, or it's been, you know, a year, you need to have your ultrasound done, trying to set up some sort of automated system so that it's not leaving the person to kind of figure it out on their own, but the system can do some of those reminders for them. So that video is kind of an infographic that we used. We also created 2 other videos, one which is a clinical encounter where we had a provider, an actor patient, and his wife come in, and he had just found out through another test that he was having that he has hepatitis B, and what does this mean for them? So that initial conversation, that encounter, that 3-minute video is also available. And then we have a third video with Dr. Mohammed Hassan, who was a hepatologist here. I believe he retired a year ago from the university, but we sat down with Dr. Hassan, he's well known in the Somali community, and interviewed him about, you know, I have hep C or I have hepatitis B now. What does it mean? I have liver cancer. What does that mean? So trying to really increase education for people. So that third video is also available. It's in 3 parts with Dr. Hassan for people that are interested in this. Some of the outcomes of the work that we've been doing is that culturally linguistic tailored health promotion projects have come out of this work. Example of that video that I shared with you and some written material as well. That partnership with local and state healthcare organizations is essential to doing this work. We're a team, a small team. SHAC is predominantly based in Rochester, although we meet virtually, but we want more people to be involved across the state. So really partnering with local and state organizations. That diversifying the workforce is really important, right? Our team is really a diverse network of people. So look at your teams. Are they diverse? Do they look like, do they speak the languages? Do they come from the communities you're serving? If not, how can you do things differently? That video that you watched, that beautiful video, was created by a medical student from the Southeast Asian medical community. The other video that I talked about that is a clinical encounter was the videographer was a Somali man and the video production manager was a Ghanaian woman. So really trying to bring more people to the table who have influence, who have the skills. And we know that they'll take the messages back home to their communities as well. SHAC as a resource for researchers, that's one of the things that has come out of this community coalition is now people who are doing research with East African communities will come and say, hey, you know, just most recently we had somebody come to our team in January to talk about they're doing a leukemia study and they want to make sure that they're inclusive of the East African community. So how can they had us look at their protocol and their consent form? And this is a volunteer group. We don't ask for anything. We are happy to evaluate people's work. And we ask that, you know, if you have an opening for a research coordinator or a research trainee, take one of the members because they really want to try to build their platform as well for our students. Other key takeaways is partnering with immigrant refugee communities is crucial to reducing liver cancer and liver disease. Building community-based early cancer detection programs is required, and that's what we're trying to do. We know in large academic centers like here, people will come, but oftentimes as a tertiary cancer center, and they're getting predominantly most of their care, at least in the East African community, at community-based clinics. So building capacity there has been really key for us, really equipping those providers, those NPs, those PAs, those doctors, primary care providers, with the skills to do early cancer detection and having a nice referral process. And the Somali community is highly oral community. Social media plays a promising role to share with evidence. So twice a year we go to Somali TV, usually in the month of October, it's Liver Cancer Awareness Month around the world. So we do a Liver Cancer Awareness Forum where we bring either a doctor from the University of Minnesota Mayo Clinic or Minji, and they do a nice network with them. And then I will join them or one of our other research members. And then just want to recognize my research team, our PI, Dr. Lewis Roberts, Dr. Isa Abdirashid Fozia, Dr. Lionel, Jessica, our medical student, and many other members who participated. But these are the initial people who helped to kind of run our community coalition. And I am happy to take questions.
I have microphones for anyone in the room. Otherwise, I have a few questions from your virtual audience. One from Clement Wilcox. Were your conversations in Somali, and did you provide documentation in Somali?
Yeah, so I'm guessing he's talking about, maybe the Clemens is talking about the community coalition or the community seminars. So the seminars were in Somali. For the most part, it depended on the population we're talking to. We would do kind of a little assessment when we got in there. But most of them were in Somali because the people we were visiting with, either in the mosques or in the community centers, were Somali speaking. And documentation, meaning consent form, the large consent form couldn't be translated into Somali. We had the shorter consent form, which was about 2 pages long. But then we would sit down for anybody that were consenting to a study, either a Somali interpreter or one of our research persons who were Somali speaking would go page by page and explain to them what every single thing said, so that they understood. So that consent process that we give people 20 minutes to do in our clinic would take up to an hour for our Somali participants. But it was something we had to do to be able to really make sure we had a truly consented group participating.
Okay, and then he follows up with, can you speak more about the recruitment of participants?
Yeah, so I'm not sure. With recruitment of participants, again, we started with the traditional processes, and that didn't really work for us. We still continue to look for our charts patients who were coming in to either a primary care appointment or were coming in to be seen by a specialty. And when we knew they had an appointment coming up, we would call them and say, hey, we know you're coming in, for example, an ophthalmology appointment this afternoon. Can you come in 20 minutes early or stay 20 minutes after your visit? We would introduce the idea of the research. But I would say 80% of our recruitment happened in the community. And we would go again to, for example, Grikar Clinic, which is across the river from here. We talked to the owner, Dr. Afqarshe, and said, hey, this is the work that we're doing. Could your clinic be a partner in this? And if you notice all of our publications, Dr. Afqarshe is a researcher. He's one of the authors in all of our work. So he allowed us for a period of 4 years, once a month, to come and set up clinic in his office, in his lobby, and recruit people. So we would, as people would come in for appointments, say, we're doing this research study about liver disease and liver cancer. It's an early detection program. The first step is to identify, do you have hepatitis B and C? There's also a questionnaire we would like you to fill out. And we would say this in Somali or whatever other language that they would prefer, and consent them on site. And then often we would have our blood work team there with us. So they gave us a little clinic room. We would do our blood draw. Everything would be done in that 1 hour. And we offered a gift card. That's the other thing. We offered a $25 gift card for every single participant.
Okay, down back.
Yeah, so thank you so much for your talk. That was really informative. Something I'm curious about, you mentioned that lack of insurance can be something that deters participants. So I was curious, it sounds like a lot of the screening that you offer is free, but I'm curious about the next steps. Are there like funding options or medical assistance that other groups provide, or are there ways to overcome that insurance barrier?
Yeah, that was a big barrier that we noticed as well. The insurance status kind of varied, and it was one of the questions at the time of consent that we asked. We had a short questionnaire we asked about when did you come to the United States, some of the risks, but then also asked about insurance status and the resources that they had. We had two options. When we found somebody who didn't have hepatitis B or Hep C and was not vaccinated, we had local public health that we could send them to, that offers free vaccination for many people who are uninsured or underinsured. So depending on whatever county that they lived in, we would refer them, give them information to how to go to public health. If we found they had hepatitis B, it became a little bit more difficult if they didn't have insurance, because of course you need insurance to be seen by primary care or hepatologist. So for example, the 3 community-based clinics, they had a person who was working on, like a coordinator person who was recruiting, putting them on insurance, helping them apply for that. So we would connect them to that individual if they were one of the people that we recruited from the community center. At the time that we were doing the study, we had a large NIH study at Mayo, where we were recruiting individuals who have chronic hepatitis B to join a cohort study. It was a 5-year, I think there was also a group it was a multi-center study, and we had a group at the U of M. U of M was doing the pediatric arm, Mayo was doing the adult arm. And this was a cohort study that lasted for 5 years and then renewed for another 5 years. But getting people on that cohort study for Hep B qualified them to get a hepatologist appointment, blood work every 6 months, ultrasound. So we would tell people about that study. In the short term, while you work on trying to set yourself up for insurance, could you participate in this? And I would say about 20% of the people said they would participate in that study. And then others who would say, these are your local resources for getting on insurance. So either the county social workers or the hospital social workers that's close to them and connect them. But that is a challenge for people, especially if they are newer to Minnesota. You have to be here for a year to get insurance in our state, or if they are between jobs, it became a difficult thing for some folks. So a lot of social work that comes with this as well. Any other questions?
Good. Any more questions in the audience? Then let's say thank you one more time for a great conversation.
Thank you all. Thank you. I appreciate your time today.